Okay, no disclosures. Start with the case. So we got a 74-year-old guy. He's got right knee pain on the inside of his knee with every step. No real pain at rest. Has tried PT, NSAIDs, and cortisone. Walks daily, but is limited by the right knee. Has a history of a left knee about 10 years ago that's happy with it. History of AFib on Coumadin and hypertension. On exam, he's a normal BMI, no swelling, has some medial joint line tenderness, decent range of motion, no lag, and stable ligamentous exam and correctable varus. So Alex, why don't you read these x-rays?
So we're looking at standing AP and lateral of the right knee, as well as AP of his bilateral knees standing, and then patellar views as well of his bilateral knees.
So what's the first view? What's that one on the far left of the screen? You said AP, but what is it?
Oh, it's like I think a notch view, which is I should know the name. I think Rothstein.
Rosenberg.
Rosenberg. I'm sorry.
And is that an AP? Is that an AP view or
no? No, it's slightly. It has the knee slightly bent. You can see directly down the intercondylar notch.
It's actually, so it's a bent knee, you're right, and it's also a PA view, so it's shot from posterior to anterior.
Okay.
So yeah, PA bent knee view or Rosenberg. Yeah, lateral AP standing and a patellofemoral view. Okay, so now go ahead and keep reading.
Yeah, and on the left side we see a history of a total knee is going through sizing, or it is, look at the patellar component or the femoral component. I'd say it's well sized. There looks like it is cemented as well. There's no lateral, but you see a box, so I do think it's a posterior stabilized knee, and looks well fixed. Tibial component also cemented and well sized, maybe in some slight like lifting off the medial base plate there, but I think it is still well fixed. And the patellar component also looks well fixed. But looking at his right knee, we see slight varus alignment with a loss of the medial joint space. His patellar component, his patellofemoral joint looks good. So I'd say just unicompartmental arthritis of the medial compartment for his right knee.
Yeah, so joint space loss, some subcondylar sclerosis, osteophytes, right? Go through the same kind of things that you always do. So yeah, he's got pretty isolated medial disease. He's a little narrow on the lateral side. He's probably got a little bit of a lateral fight, but overall decent looking in the other compartments. And then just the other comment is this stuff under the medial tray here is totally fine. Sometimes you'll see lucencies as long as it's not going all the way around, and patients asymptomatic anyway. So that often happens with older implants, and especially with implants such as this one, which are a stiff tray. It's a cobalt chrome tray. It's stiffer, so it stress yields a little more, but yeah, that's fine. So he's saying, Kazzy's saying, what do you recommend for this guy? He'll go with whatever you tell him. So what would his options be at this point? He's already done non-op, so we'll skip that. Operative options for this gentleman.
Yeah, I think given that he has isolated medial OA, I think that it would be reasonable to recommend a unicompartmental replacement, especially given we're talking about that this lecture. And you can talk about a little bit about the possibility that in the future he might need a TKA, but a
we'll stop there. We won't go. We're gonna kind of, so good. Yeah, you could talk to him about a UK, or you could talk to him about a total, right? Those are probably the two options that we could talk about for this guy. So purpose of today, what we're going to try and figure out is identifying people who are actually candidates for UKA, being able to counsel them. So I think this is important for anyone, is kind of being able to compare the two in terms of what are the differences, why pick one or the other, what are the consequences of that decision. And then also I want you guys to be a little bit familiar with the types of implants that partials can do. We're going to focus on unis, and then I put a little bit in here on patellofemorals as well. We're not going to really talk about the comparison to HTO. If you look at the literature, every comparison of HTO versus uni like destroys HTO. So most arthroplasty surgeons would say no one should ever get really an HTO unless they're like 20 or low 30s. That's like the only population you consider. But okay. So is he a candidate for a uni? So the biggest thing is going to be radiographs and physical exam. For this guy, we also have the other decision-making factor that he's happy with the total. So why change things up? And then he also has some medical comorbidities with he's on Coumadin for Zika. So let's see, churches. You're on arthroplasty. What are the indications? Classical. This is the Cozen and Scott article that was like the classic UKA article. What are the original indications for a partial, let's say medial partial knee replacement? Who's it designed for? If you had to pick the perfect patient. You're muted. You're still muted. You remain muted. Is it just me that sees him muted? Or am I frozen?
No, he's muted.
Churches, unmute yourself. That's not an excuse. We've been Zooming for 18 months now.
Sorry.
Oh.
Sorry, I'm in the same room as Hunter, so I was trying to talk through his speaker. Not sure if it worked. But the classic indication is someone with isolated medial compartment arthritis or degenerative changes, being sure to really scrutinize the lateral and really the patellofemoral compartments to make sure that there's no evidence of change there. And then in terms of, we talked about in this patient, the varus deformity, I think it needs to be a correctable deformity. If it's fixed, it won't do as well.
There's a lot of other things. What are some other ones? Hunter? We got a lot of things, a lot of check boxes you got to have with a uni. Hunter?
Oh, sorry. So some other things you think about, you need an intact ACL. And then you also need, you need to not have like an inflammatory arthritis, like a RA or something, because then you'd expect it to, affect the other compartments over time.
Yeah, a couple other things. So, isolated arthritis, like you guys talked about, you have to have not a severe deformity. So they originally described angular deformity less than 15 degrees that's passively correctable. And the key there, though, is passively correctable after osteophytes. So you can do some balancing. Intact collaterals, decent range of motion, and then a non-inflammatory style arthritis. And originally this was designed for older patients and light patients. So old, low demand, lightweight. This may sound a little strange to you guys because if you've seen it now, the indications are much different than this, okay? And contraindications were inflammatory arthritis, chondrocalcinosis, if you start seeing any of those changes in the meniscus turning into bone or into calcified, and then if you have any arthritis in the other compartments. Now that classic indication of meeting all these parameters, the Cozen and Scott classification, really only applies to about 4% of total knee cases. And so you have kind of this differing kind of camps, and you actually probably see it. We're probably close to about 4% in our practices here because most of us still adhere to sort of closer to these original standards. But then there's a lot of centers in the country where 60% of their knees that they do are unis. So how does that happen? And it's because there's been kind of this creep in the indications. Now it's actually probably more often pushed for the younger and active patient as opposed to the original indication, which was supposed to be an older, low demand patient. People put it in BMIs way above 82 or 82 kilos. And, there's papers that you can prove one way or the other if that's good or bad. There's people putting them in now with ACL deficient knees. There's people doing it at the same time as an ACL reconstruction. There's people who say you can ignore other compartments like the patellofemoral compartment with no difference. So there's kind of all these, like, you can find your evidence to support whatever you want to do, with the exception of probably the inflammatory arthritis now. So that's why you'll see this differing in terms of, like, even amongst our practices, like Dr. Beanie's pretty aggressive with unis. The rest of us are very, very conservative. And a lot of that has to do with, we see a lot of the complications of them here, and it's just not, it hasn't been as much something that we want to push. So yeah, so this is probably too much, doing like a uni with a combined ACL reconstruction. So now why not just do a full knee replacement when the other one works? So AJ, what's some theoretical advantages of a uni versus a total? Like, why does this even exist as a procedure if totals work pretty well?
Yeah, well, I think some of the just practical surgical advantages, maybe you're just, it's a shorter operation, potentially less blood loss, you're taking less bone, so it's less painful of a surgery, so patients are able to get recover more quickly. And in terms of kind of like biomechanics of the knee, you're not resurfacing the entire knee, you're allowing some of the native joint line to remain, so that may help with just preserving some of the normal kinematics of the knee and make it feel more natural to the patient.
Yeah, really good. So, most people would agree that the knee kinematics are closer to normal, and it doesn't have so much to do with preserving the bone and stuff. It's more that you have all your cruciates, both your cruciates and all the ligamentous structures are the same. There is some change in the kinematics of the knee because medial side is supposed to be pretty conforming and not move very much, and the knee will still kind of move without the on the uni. Less perioperative morbidity is another big reason. So, it's not as stressful of a surgery to the patient because it's usually less blood loss. You're not instrumenting canals. It's just a smaller surgery. And then the rehab is usually a little bit quicker because you're just not doing as much inside the knee. This is looking at all of the complications that can happen after a partial compared to a total. So this odds ratio is comparing unis versus total. Less than 1 is going to favor a uni. And you can see pretty much all the complications, all the serious complications are favoring uni. Understanding that these are matched, but it's not a randomized control trial. So there may be some selection bias here in terms of which direction or which surgery again. Now, Sarah, in terms of, oops, oh, I can't do that way. You're off the hook. So how long does a uni last compared to a total? Now, this is the big drawback. So if you said to a patient, like, you are a candidate for a uni, you're going to recover faster, it's less perioperative morbidity, it's going to feel like a more normal knee, everyone's going to want to sign up for that. But the downside of it is that the revision rate of a uni is about 3 times that of a total. Okay. In every registry, it always comes out at about 3 times the risk that a uni is going to need to be revised at some point. So this is from the England and Wales registry, looking at years post-op and the survivorship of a total versus a uni. This is looking at the Australian registry, the Swedish registry. All these are better registries that have good capture. The US registries are terrible because we don't really capture anything that gets revised. So we can tell you the number that went in, but not what came out. So if you're looking at kind of, this is 13 years out in the Australian registry, totals, about 93% survivorship. That's really good. Unis, only about 80. Okay, and the same kind of trends persist in all of the registries, that the uni revision rate is a little bit higher. So Sergio, what might be some reasons that you can think of that a uni, or so let's take a step back. So what are the reasons a uni can fail, number 1, and then number 2, why do you think it's failing more frequently than a total?
Just some prosthetic reasons, I guess. Specifically when you look at like the fixed bearing device, it's like with your poly, you're kind of like putting all your pressure on one point. So that could be like implant specific. And then also like progression of arthritis to the lateral side and patellofemoral joint. And also, like, like there's a reason to revise, like you're more likely to, if a patient's having knee pain, you're more likely to revise it to a total, but with the total, there's not much more you could do in a painful knee sometimes.
Yeah, I think you're hitting on some good points. So, we'll go into these failure mechanisms. Now, in terms of the, what did I put here? This is just saying that if you do very few unis, you're more likely to run into complications. And that's one reason that it might be more failure mechanisms, is an unfamiliar procedure. So if you look at the UK registry, most people are only doing 1 or 2 unis a year. And then if you look at the failure rate of the cases per year, you can see that the failure rate is much higher for these low volume surgeons than the high volume surgeons. That makes sense, right? And so they came out with this recommendation that you do at least 1 a month to try and stay proficient and keep your revision rates acceptable. So that's one reason potentially. The most common causes of failure, like you mentioned, number 1 is wear, or number 1 is wear. Number 2 is loosening or adjacent compartment degeneration. Other things that can happen with unis are dislocations of the bearing or plateau stress fractures. And then, like you mentioned, a painful uni, a lot of people have painful knees, right? So painful total knee is about 15% of cases. You have a painful uni, it's much easier to pull the trigger to convert it to a total and just say, I don't know what's wrong with it, but we'll just convert it. As opposed to a total knee, much harder to pull that trigger because it's not as big of a surgery. This is looking at the reasons that unis versus totals fail. So loosening and lysis are the number 1 reason for both totals and unis in this registry. The number 2 reason for a uni to be revised is just pain. Okay. Number 3 is for progression of arthritis and other diseases or in other compartments. Wear is kind of a, loosening, lysis could be wear. So some of these kind of go against each other, but notably infection is not a high reason for revision of a uni, whereas infection is a very high rate in total. So that's a big difference between the two. Instability is usually not a reason a uni is revised either. Now this is getting at your point that a painful uni is more commonly revised because there's a lower threshold. If you look at quote unquote people who had unsuccessful surgeries from both, and you go by one of the patient reported outcomes in Oxford knee score, people are 60% of people at a bad outcome in a uni get revised, but only 10% of the totals get revised. And that's just that threshold of kind of pulling the trigger. It's a lot easier to pull it. And then these are 2 other registries looking at, or another registry looking at the reasons for revision are much different. So loosening, lysis in both, maybe an old poly problem, maybe not as big of a deal today. Loosening though, probably. And then progression of disease versus infection for the total. So now if you revise a uni to a total, it's probably somewhere between a primary knee and a revision knee. So it's not going to have as quite of an easy recovery and outcome as a primary knee. The success rate is going to be a little bit less than that. Some of that's, again, selection, that this patient's already failed something else. And some of it is that it's a little bit more technically challenging with surgery, but it's not going to be as big of a recovery or as painful as a revision knee. Okay, so when we're doing a uni or a total, there's some different principles than in a uni. So we talked about these in the last few weeks. The principles of a total knee, you're trying to get so not a kinematic knee, but a total knee, traditionally, you're trying to get a mechanical axis, restoring the joint line height, balancing the soft tissues, having equal gaps, and restoring the patellofemoral alignment. A uni is a little bit different. So in a uni, we're doing more of a kinematic type procedure, which is replacing the articular space that's lost from cartilage loss, filling, preserving the shape and size of the condyle, and restoring the limb alignment to what it was pre-pathology. So this is more kinematic principles in a uni. We're just trying to resurface and balance back to pre-disease state, as opposed to in a total, we're trying to build this back to a neutral mechanical alignment. The ultimate goals, though, are the same: pain relief, durable construct, and getting able to do back to the things that they want to do. when you're trying to perform a uni, we do still put the tibia at a neutral mechanical alignment. There's some evidence that a couple degrees of varus, so 1 to 2 degrees of varus, is actually probably better than neutral. But we're not that good. So most people will still shoot for neutral. And then most people will do some sort of gap balancing to get the femoral rotation, the femoral sizing. But this is a lot more native, similar in terms of slope, native in terms of size. Avoiding overcorrection. Let's see. Who has seen a uni? Has any of you guys, or let's put it this way, who has not seen a uni? 1, 2, most of you. Okay, I can't see half of you, but most people with videos have not seen uni, so we won't talk about this too much. You all have done a uni though, right? The people who did that VR thing. So you can't say you haven't seen the instrumentation. But basically, when you put it in, you're trying not to do a lot of releases other than taking bone spurs off. You're trying to take as minimal bone as you can and still get the stuff in. You do put it in a little looser than a total because you want it to be more like a normal knee. Now, in terms of implant choice, one of you guys mentioned types. Joey, can you describe the difference between a fixed bearing and a mobile bearing on a uni? What's moving in the two, and how are they shaped different?
Sure. So the fixed bearing, the poly will be, flat and kind of locked into the tibial base plate. Whereas a mobile bearing design will have a curved poly that is allowed to slide on the tibial base on the base plate, so it's more mobile.
What might be the purported advantages of one versus the other?
I believe for the mobile bearing, I believe they have a better feeling that it's more like a normal knee since there's more motion, and it kind of allows the knee to move more freely. Whereas, and I think the disadvantage of a fixed bearing, kind of like Sergio mentioned, was all of that, since you have a flat poly and a curved femoral component, all of that force is kind of onto one point onto the poly, so you can have some accelerated wear.
Yeah, I think the movement thing is probably not accurate, so most people wouldn't say that it's a more normal feeling knee. The benefit is theoretically with a mobile bearing, because you have that highly constraining or highly conforming poly. The poly fits, I think I have a picture here. So the mobile bearing is over here on the right. The poly conforms very well. And so you're distributing that force over a larger area. Theoretically, that's going to be less wear. With a fixed bearing, you are point loading. And so there may be more wear. You also get some shear going on top of the poly as the condyle moves on the tibia. That can cause more wear. Shear is usually worse for poly than kind of that adhesive wear, which is with the movement of a conforming surface. Now, the disadvantages of the mobile bearing are it's a little more technically demanding. You have to get the balance right. If you don't, that poly can spit out, which is a unique complication. It's like 1% of mobile bearing unis will have some sort of dislocation problem, but it's not 0. And there's really only one company that makes it called the Oxford, and it's a little bit futzy. All right, if you look at the outcomes for it, survivorship can be very good. Rich Berger is a guy from Rush who does a ton of unis, has published a lot on unis. You have to be careful about some of these survivorship studies from people who do a ton of them and are kind of designers. It's not necessarily going to be what's going to be your outcomes if you tried to do it. These guys are doing thousands of these, and so inherently you're going to probably be doing better than people doing 1 or 2 a year. So registries are probably better to look at what is the overall survivorship, but if done properly, they can do very well. Yeah, no overcorrection. Same with the mobile bearing. Mobile bearing can do very well. And this is a side view of that thing. That poly can just slide on the tray. The other advantage of the mobile bearing that I didn't mention is that by allowing it to slide on the tibial tray, you're theoretically reducing the force through the tibial component, so that might have less stress on the tibia.
Dr. Can I ask
yeah.
a potentially dumb question? Why not have a fixed bearing design, but have that poly be conforming to the femoral component?
So that's a good question. So if you have what might happen if, say, you put this locked plate in there with this kind of curve like that, what might be the downside of that? What's going to happen if you have a highly conforming implant?
I guess motion. Yeah, I guess you're limiting motion.
Yeah, you're limiting motion. The knee needs to kind of be able to slide and move a little bit. You have to, if you're totally constrained, right, that's a hinge, right? And a hinge, we know, doesn't work without some sort of rotation. You have to have some way to dissipate some of that stress. If you just lock the two together, you're putting a ton of stress at the implant bone interface and they will loosen. Okay. So if you were to put a fixed bearing on the tibia, it's locked in the tibia, and then you have a highly conforming knee, you're not allowing that rollback to happen. And so every time it tries to roll back, the ligaments are trying to roll back the tibia. It's just forcing on that poly. And so you either get really rapid poly wear, or you'll get the tibial component will just rip out. So you have to kind of do these trade-offs of, you have to dissipate the stress somewhere. It's either through some sort of mobile bearing, or it's through less conformity on the polyethylene.
Okay, thanks.
Well, in terms of the survivorship and registries, the fixed bearing ones are actually the best survivorship. So the one that the most commonly used in the US is called the Zook. It's the one that you'll see like Beanie uses and I use. It's a fixed bearing prosthesis. Oxford is listed here, you know, probably about double the revision rates of the Zook, which does quite well. But this is in Australia, where the Zook is not necessarily the most frequently used. They're using the Oxford the most commonly. So this is that's not even my implant. I think that's Dale's maybe. That looks like a DePuy. So one thing to know when you're reading X-rays of a unicompartmental knee. So number one, you want to look at the slope and see how they restored the native slope. Number two is a lot of times you'll see this implant kind of tucked underneath here. Is my arrow on the front or the back? Ellen, is my arrow in the front or the back of the tibia right here?
I think
is that part of the
front,
anterior or posterior?
Anterior.
Posterior. So when you're putting these implants in, you're kind of cutting right along the spine, and so a lot of times you'll cut back posterior. So this is always the back, and this is the front. So a lot of times you'll see this though, where it looks like it's underneath the ACL spine, but it's not. It's just kind of going behind. So that's something to be aware of. You want to maximize the size of this, so you want to see the implant kind of right out to the edge, maximizing the AP size. And then on the patellofemoral view, you want to see some sort of kind of continuity of the curvature there. But that's fine. I'm going to skip that. What about robots and unis? So there is a lot of data. A lot of the early robot implementations were around unis because it's a more technically futzy procedure. And the robot is actually much better at getting these in at the right kind of coronal balance. But it has never been shown to be better in terms of long-term survivorship or patient outcomes, unfortunately. So it's better at hitting a target, but that hasn't resulted in any kind of improvements in long-term anything. It is a fun procedure too, though. And you guys will probably see this as a junior residents. There's a Mako coming this summer, so you'll probably see me start doing some of this stuff, and then there will be a DePuy robot coming sometime next year, so you'll get to see some of this. So unis, like anything in ortho, you can find evidence for anything. I think most people would say sticking to historical indications is going to be the safest bet, and then you can start expanding as you have success. 12 a year is probably what's needed to be proficient. I would say most of us don't hit that in our practices, especially in an academic center. So there's probably more and more push to kind of funnel towards one person. So in our group, we mostly funnel to Beanie to do most of the unis, just because that's what he did a ton of at Kaiser. So he does most of the unis. And the rest of us kind of just stick to totals. Now, patellofemoral arthroplasty is a little bit of a different beast. It's much less common to have isolated patellofemoral disease than it is isolated medial disease. Usually it's kind of post-traumatic from instability. Same kind of indications though in terms of conservative things first. And then another important thing about patellofemoral arthroplasty is you have to not have significant malalignment. And the majority of patients who end up having this are kind of women in their 40s and 50s. Contraindications similar to medial unis, no inflammatory arthritis, no arthritis other compartments. Don't want to do it in super obese, want to have your ligaments intact, no flexion contractures, no blah. Long-term outcomes are not as good for this compared to other types of replacements. This is definitely of all the replacements that we do the least successful. About 80% survivorship at 10 years. Most of this is happening because of progression of arthritis in other compartments. There's some different styles of implants. Who's been on arthroplasty? Fabian, what are the there's two main categories of patellofemoral replacements. Do you know what they are?
I do not.
So there's called an inlay and an overlay. So an inlay patellofemoral arthroplasty, what it does is it kind of puts the implant right where your native alignment was. So it kind of finds the groove and you put it back in that groove and you're kind of putting it in line with the rest of the trochlea. An onlay patella is more similar to what's done in a total knee, where you make a flush cut and then place a new trochlea over the top of it. The advantages of an onlay, and the onlay is what most people use now, is that an onlay you're able to recreate their anatomy to what's maybe more appropriate for a replacement. So if their trochlea is hypoplastic, it's off to the side, it's not in the right position, the rotation's off, you can fix that with an onlay, as opposed to an inlay, you're driven by whatever their native anatomy is. So most of these implants are now going to be kind of these bigger shape, like the second generation that kind of sits on top, as opposed to the older generation, which sat inset and was just in line with wherever their trochlea was. Obese people do worse. Probably has to do with this reactive force thing. So this is something that's helpful to talk to patients about, regardless of their type of arthritis. But the force going through the patella is about 5 times the body weight. So every pound is 5 pounds off of their knee is a good way to describe it to them. And the locations of this have changes in your inflection. It's important also with a patellofemoral arthroplasty to note that once they get past about 90 degrees of flexion, they come off of the patellofemoral arthroplasty. Okay, so they're back on their native bone. And so if they're getting most of their pain in deep flexion, a patellofemoral arthroplasty is not going to be a good solution. It's more for kind of stairs and more biking, things that are more in the 0 to 90 degree range that are giving them trouble, as opposed to deep flexion activities. In terms of converting the patellofemoral, it's actually super easy, and it's actually very, very close to the outcomes and length of surgery and everything for a total. And that's because it's just really easy to whack it off, and that anterior cut's already made for you. You don't really lose any bone. The anterior bone is not really a big deal for balancing. So it's very similar to a primary knee and converting a patellofemoral arthroplasty, more so than converting a total. And as a result, I think people are a little more easy to recommend this if it's isolated, because then if you have to fix it, it's not as big of a deal. You're not burning any bridges. So often this is used as a temporizing measure to just get people to a total, maybe 5 to 10 years down the road. That's kind of where I would use it. Okay. So why don't you do this one? All the following are contraindications of medial uni, except which of these?
Yeah, so the choices are flexion contracture greater than 15, varus deformity greater than 10, not correctable, lateral knee joint line pain, rheumatoid arthritis, osteonecrosis of the medial femoral condyle. So all the following are contraindications except, so I know lateral joint line pain, rheumatoid arthritis are, so those aren't it. Varus deformity that's not correctable is a contraindication. Flexion contracture is a contraindication. So just by process of elimination, I would go with 5.
Yeah, good. So osteonecrosis of the medial femoral condyle, actually people do really well. That's one of the most common indications for a partial, a uni, is if you get AVN of the medial condyle. Now, obviously that's with a caveat, it can't be huge, but it has to be something that you can cement into and still get stable fixation. But they do quite well if you have AVN of the medial condyle.
Dr. Barry, would you get an MRI for these patients preoperatively to make sure it's not more diffuse?
You can, yeah. So a lot of us will. Beanie gets an MRI beforehand. The reason to do it is twofold. Well, if the patient is very much adamant that they only want a uni, I would definitely push to get a MRI beforehand. And the reason is then you have an idea of what the lateral and patellofemoral look like, and it can better give you a discussion with the patient. If the patient is kind of like, if the rest looks good, I'll do a uni. If not, total, I'll leave it up to you. Then I would probably be less pressed to do it, and we would just look at it intraoperatively and decide on the fly. But it depends on how much the patient is leaning one way or the other. Okay, it can be helpful to know what the other parts look like, or if you're worried about the ACL or worried about one of the ligaments, that can be helpful to do that. Good question. The other thing that kind of we don't mention is, we talk about cartilage loss in the other compartments. A lot of times there'll be like a significant meniscal tear on the other side. And a lot of us won't do a uni if you have a bad meniscus on the other side, because it's a marker that something's about to happen or you're about to start going downhill if you have meniscal pathology on the other side. Okay, Alex, why don't you do this one? 61-year-old invasive uni, 8 months ago, did well recently, now has worsening pain with weight bearing, no fevers or chills, infection workup was negative. Here's his x-rays and a bone scan. What do you make of this?
Yeah, so we see this AP of the unilateral, and then bone scan with positive uptake in the tibial component. With pain after 8 months, I'd be most concerned with the stress fracture of the tibia.
Yeah, good. How does a stress fracture happen in a total knee or in a partial knee? What's the mechanism usually?
I know there are risk factors intraoperatively that you can avoid, such as placement of guide pins and where you make your cuts. I don't know them specifically off the top of my head, but I know those are some of the risk factors. Yeah,
so if you put a ton of pins, that's one way. So a lot of these will fracture through one of the pinholes, or you'll get a stress fracture through one of the pinholes. That usually will happen early on. If you undersize the component, you're putting way more stress on a smaller area. That's another way that stress fractures can happen. If you undercut the ACL too much, you can get a stress fracture with the ACL popping off. So that's another fracture that can happen. And then if you're obese, that's another way that you're just putting too much stress through a small implant. You're just much more susceptible to these in the partials as opposed to the totals. So good. This guy has a stress fracture. I don't think it's through a pinhole, but yeah. All right, I think we got one more, maybe churches. All the following are contraindications except.
So, yeah, okay.
We'll go traditional.
Anterior compartment osteophytes and pain beneath the patella, medial sided knee pain with medial and lateral compartment osteophytes and 3 degrees of varus deformity. Lateral sided knee pain with degenerative changes isolated to the medial compartment and 7 degrees of varus deformity, flexion contracture of 3 degrees. Okay. Are contraindications except, so ACL deficiency is a contraindication. Pain beneath the patella, there's another compartment, so that's a contraindication. medial and lateral compartment osteophytosis is a contraindication because there's another compartment involved. Lateral sided knee pain with degenerative changes in the medial side. Since the lateral side is painful, I would say that it's not isolated to the medial side and you shouldn't do it there. And then flexion contracture of 3 degrees. I think that you could still do a uni with the flexion.
You can do it with up to 5 degrees. Now, do you think that you're going to be able to correct that flexion contracture at the end of the case?
You could potentially, if you take a little more of the distal femur.
Is that going to work in a partial?
Probably not, because you saw on the other side.
So yeah, be careful. You're mixing concepts here. So taking more of the distal femur is a total knee concept when you're trying to balance the extension gap. With a uni, remember it's not creating a gap and then matching to it. It's you're matching the soft tissue envelope that's already there. So you can't really change much that isn't already set. So that's the whole reason that it needs to be a correctable varus. That's the whole reason that you don't want a ton of flexion contracture because you're not going to be able to fix it very much. Some of it may get better. A lot of times the flexion contracture develops because it's more painful and full extension, so they may be able to stretch it out, but you're not going to be able to do any releases or any changes to your cuts to get more extension. So that's an important concept, okay? But up to 5 degrees is generally tolerable, so number 5. Let's see. And then, so benefits, I'm just going to tell you guys pretty much done. We talked about this. The benefit is the only one that's been shown consistently is that a faster post-op rehab, okay? The rest of these are not. Clinical outcomes are pretty similar. Survivorship is lower. The alignment is going to be different. You're actually going to have worse alignment with a uni than a total, right? Total, you're usually correcting alignment. And then a higher risk of surgery at 1 year. Same thing.